Please welcome our next two guests who will explore innovations in obesity care. Dr. Angela Fitch is president of the Obesity Medicine Association, and Dr. Kavita Patel, primary care physician at Mary's Center and senior policy advisor at Stanford University. They are joined by our editor-in-chief, Bob Cusack.
Thanks for joining us. I wanted to start a question for both of you. Just a general question, but Angela, we'll start with you. What are the greatest barriers to obesity care right now?
Well, that's a little bit multifactorial, but thank you so much for asking. I do think it is, as Dr. Fauci was here, talking about COVID and HIV and other epidemics that we've dealt with, pandemics we've dealt with. I think, the biggest barrier to care today is actually access to care in two ways. One is the insurance coverage of care, and the second thing is the sheer access, the sheer volume of patients that are seeking care today.
Okay.
And so I think it's complicated by both of those things. It's not just a one and done issue. I'll say the third thing I will say is the stigma and bias. So
Right.
The stigma and bias around accessing care is getting a lot better, much like mental health. 20 years ago, when there was a lot of stigma around accessing mental health, that's gotten better, today.
Right.
I think we're where we were with mental health 20 years ago with obesity, right?
Okay.
Like we're still at that stage of people finally trying to, finally feeling confident that they can actually seek care without being discriminated against. And that's where we gotta work to get to.
Kavita, your thoughts on that?
Oh, I think it's not just multifactorial, but part of it when Secretary Vilsack was talking about kind of SNAP and WIC. I mean, we're seeing children now, and the food we're handing them as part of like our supplemental benefits programs are nothing short of criminal. Part of what we have to do in our clinic is actually swap out what is subsidized by the federal government, by taxpayers,
Right.
because it's such high density caloric juices, highly I tell parents, if it's got an ingredient list that you cannot actually interpret, you should not be putting it in your child's mouth or your mouth. And lo and behold, what we hand people is just packages of these highly processed foods. And then on top of that, we do such a poor job with we have such a blended cultural country, such a global country, and we do zero education in nutrition, and all the nutrition education we give is frankly angled in it's anchored in a very kind of Anglo kind of traditional, foods I never ate as a child because I grew up in an Indian and kind of Hispanic household.
Right.
So they were things my parents would never buy and recipes we could never follow. And so when you start things at that, and then add to that most mothers or fathers are working, don't have the ability to prepare lunches and meals and have to really depend on the school system, which also depends on those highly processed foods that are subsidized by municipalities, states, and countries, we have set up entire generations at a disadvantage. So that is absolutely something part of our fabric, which is why, I know there's too much to talk about, but it's why I'm frankly incredibly excited that we now have multiple ways of dealing with obesity, which I describe as a chronic. It's just like diabetes, it's just like any condition, heart disease, everything. It's of a similar ilk in its multifactorial nature.
Yet it's not a standard benefit on insurance coverage for Americans today to get access to care. Our clinicians that, I'm with the Obesity Medicine Association, which I'm honored to be president of this year. We are 5,000 clinicians of people who do obesity medicine, take care of patients, for this chronic disease. And yet I have clinicians, reporting to me every day that their bills are getting denied from Blue Cross Blue Shield because they billed for obesity. And that person's plan doesn't cover anything related to obesity because that's cosmetic, or that's something that is seen as being elective type of treatment, not a chronic disease.
Kavita, and I remember I used to cover healthcare. In 2004, Medicare labeled obesity as a disease.
Right.
However, there are still massive access issues. What do policymakers need to do, whether that's Congress or the administration, CMS, et cetera?
I think absolutely kind of dealing with the access issue by cutting through. Anybody who's ever tried to access any of the benefits, that even if they're dictated as benefits of your insurance program, whether it's prior authorization or death by thousands of paper cuts. I mean, we're the only industry that still depends on facts for everything, which is bananas. But that's so. What we do is make the process, as you know, so onerous and difficult, and so dependent on an individual who, again, has usually 1 to 2 full-time jobs, has a family to take care of, has a ton of other responsibilities, and doesn't speak legalese. So I think that cutting through, whether it's prior authorization or being incredibly clear, part of what Nancy Pelosi's office was really trying to do that I thought was incredibly admirable in one of the recent kind of budget showdowns was to try to get a Medicare navigator benefit in place. And I will tell you, I am board certified. I don't know how many degrees the three of us have between us. Even I sometimes cannot navigate my own health care benefits, and I am probably the most educated person in my household on it. So having some way to be able to sit down and say, here's what I can and cannot get access to, here are the pharmacies and ways I can get things that are the cheapest and also still offer kind of what my doctor is probably prescribing for me. Those are all the kinds of things that I think we could, as policymakers, support, but we don't. And so we like to kind of point fingers. We'll point fingers at pharma, we'll point fingers at doctors, we'll point fingers here, when the truth is that we created the system that we wanted. And what we've done is created more of a kind of utilization management system where it's so hard to get things that you end up just kind of throwing your hands up and kind of calling it a day. And then the training piece, I think Medicare is the primary driver of residency, fellowships, student training. Still a large funder of a lot of these programs comes from Medicare funds, but we need to probably be a lot more pointed about saying these are some clear competencies, even if you decide to go off and become a cosmetic dermatologist, which is what my sister does, and I wish I could benefit from that locally sometimes, but my sister, who just does like a cash pay practice, benefited from a Medicare training program, but we should have some core competencies that even she is required to do because she did benefit from this access and this training. And so I would love to see nutrition, obesity counseling, mental health training. A lot of these things should be core skills on the provider side. We just heard Susan talk about like a primary care crisis. It's all the more reason everybody needs to have some versatility. Your surgeon should understand some of these things, for example.
You both are on the front lines on dealing with patients and patients with obesity, and we were talking before we came on stage about Ozempic and their alternatives or similar type of drugs, and I think a lot of people think, okay, well, we're going to solve this problem with drugs, and the demand is so much. Angela, go to you first. Can you tell us what's going on the front lines on this issue of the demand of getting treatment that people think will be the perfect remedy?
Well, and again, we're talking about the advancement of science. As we heard earlier, I mean, science has advanced. Lifestyle interventions, so focus on diet and exercise, which is the basis of all treatment. We all have to do lifestyle interventions every day because the world we live in is not inherently healthy. So all of us, I think, should have access to a dietitian, someone to help us that are going to help us to live healthier in our environment today. Because by living defaultly in our environment, it produces excess adiposity or overweight and obesity, right? We have overweight and obesity, 70% of the population are dealing with this, and it's because we're living naturally in an environment that produces such. And so we all have to have that lifestyle intervention at the basis. So it's important to say, we're not just out here saying we need to treat everybody with medication. But when medication comes around, that now is 10 times as effective as lifestyle intervention. So lifestyle intervention produces on average a 2 to 5% weight loss. Yet we expect it to produce a 20% weight loss, right? But it only produces a 2 to 5% weight loss. That's not because it's bad, it just isn't very good for treating obesity. Right? I mean, it's good for other health conditions, but many of our conditions, hypertension, diabetes, many of them have a lifestyle component. Yet we layer on top of that the science of medication. And our science has come so much further that it should be almost unethical or unconstitutional, or since I'm here in Washington, D.C., I can say that, right? It almost should be something.
That said a lot around here.
But it's almost to be something, to not be offered something that now is 10 times as effective. Right? I mean, you're able to now lose 20% of your weight, which infers a cancer risk reduction. It infers a cardiovascular risk reduction. It infers a lot of different help, for you to live a longer, healthier life, 8 to 10 years of increased life expectancy when we get that 20% weight loss. And we can now get that more often than not with our newer line of pharmaceuticals, with our newer interventions pharmaceutically. And so that's why the demand has gotten so great, is that patients now recognize that their person next to them in their office or their neighbor or someone else, I said, just like with the mental health issues that we had 20 years ago when we had SSRIs come about, which were much more effective and much easier to manage and prescribe and to take from a side effect profile, then more people were taking it, more people were feeling better, more people were accessing the behavioral interventions they needed in therapy. And that's very similar to what we're talking about here. And these medications are just so effective in helping people. We need to do something urgently to try to provide better access to effective treatment, because it really should not be allowed, for people not to have access to that.
Kavita, your experience with patients who want access to these medications?
Yeah, I work kind of in what's called a federally qualified health center, so the majority of my patients are Medicaid patients. And to be honest, they're probably some of the very few people that don't come in kind of asking for a specific medication, unlike maybe a weight loss clinic or a place like Angela that you ran at the Mass General. I think that most of them they're diabetics, many of them are on insulin, and I kind of said, this is something that can get you off of insulin, off of your other medications, and also have 20% kind of weight loss, et cetera. So these are like the perfect candidates for which the trials were done. They are the right people. And even still, I sometimes have trouble getting access to the medications for a lot of reasons, including just the fact that we're out of many of these medications due to people who are probably not the right candidates to get the medication asking for them. So we end up I spend a lot of my days kind of calling pharmacies, trying to figure out who's got which dose at what time and when can we make sure that a patient doesn't run out of their dosing, especially as we're trying to get them to a maintenance dose. But these drugs are nothing short of miraculous. But I use the same kind of commentary that I do for my diabetic patients on insulin or on any other treatment. I wouldn't deny a diabetic their insulin medication, because that's something that's just a fundamental property of their disease, just like obesity. And then on top of that, what's been remarkable about the drugs, and it's been documented, but it helps turn off that kind of social and emotional noise that happens with food. So regardless of the different factors that lead to your obesity, the medications have been stunning, but I do tell people, Bob, they're going to be on them the rest of their life. And so I'm an internist, so I primarily see my average patient is in their 40s and 50s.
Right.
So we're talking about a game changer for them, but it's something that I tell them, this isn't something you're going to be on, lose weight, or get off your insulin and then go off of. This is a part just like your insulin was. It's part of your chronic, the medications that we use for you. I think that there's a lot of because of social media and TikTok and Instagram, I think there are a lot of also people who want to get access to these prescriptions who will come to me, and then when I find that they're not the right candidate, they want to lose 10 pounds, for example, Bob, they're not the right candidate for the particular medications that we currently have, and candidly, I know that there's probably better ways to do that weight loss for different reasons. Then honestly, what they will do is they'll leave my office and they'll usually go into an online. There are numerous companies popping up on a daily basis. They'll sometimes get them those prescriptions. And then I end up inheriting them back when they get the initial prescription. Then they come back and they want to integrate that into their care. And I tell them that that's not what I'm going to do. And so it's very interesting. We've developed kind of a parallel hack around for a seemingly large population that might not be the appropriate target for this particular set of therapeutics. But it is a renaissance. The way we're dealing with obesity, I'm hopeful that in my lifetime, just like we've talked about HIV and cancer and genetic therapies, I really do think we're on the precipice of doing something significant. When you look at 40% of adults being obese and then look at children in obesity, something huge that could change the American, just so much about what we do in America, productivity, mental health, so many of the things that we've talked about.
In a couple of minutes, we'll open up to questions. Angela, I want to ask you about legislation that's been introduced, and not many measures in Washington are bipartisan, but the Treat and Reduce Obesity Act has been previously introduced in the House and Senate. Again, has Republican and Democratic co-sponsors. Can you tell us about this bill, and do you think it's going to get done in this Congress?
I hope so, because we've been lobbying for this for over 10 years, I think. I can't remember how long exactly it's been on the books, but it's been a long time, and it's time to do it, right? And we have to, we understand that there are cost implications to treating obesity, but there are also dramatic cost savings, as Dr. Patel mentioned, getting off other medications, having higher productivity, having a higher quality of life, not needing treatments for cardiovascular disease, stroke, other types of diabetes complications, kidney disease, dialysis. All of these things get better when you treat obesity. But we have to do it for the right. We just have to do it because we need to do it. It's almost like COVID. We didn't stop and say, well, how much is COVID going to cost us? Can we afford to cover it? No, we didn't stop. We didn't stop and say that because it was an urgent pandemic that was killing people. This is an epidemic. Obesity is an epidemic that is killing people. It's just killing them very slowly. And as Dr. Patel mentioned, I'm an internist as well as a pediatrician, and with 20% of our adolescents and children having obesity now too, it is taking 8 to 10 years off of their life, and we're just allowing it to continue to happen because of the idea that it's going to cost us too much. And I think there are other solutions that we can work on, right, around cost. As far as who does, how do we access treatment? Who should get treatment first? And then also, working with different companies like we did with COVID, to come together and say, hey, how much does it really cost you to make it? Can we figure out a way to, get it at a different price? The VA pays a substantial less amount of money for these medications than my patients do at the pharmacy, right? Because of their negotiating power, et cetera. How can we do that, right? How can we really improve access for everyone?
I want to open for questions. We've got a few minutes left. If you have a question, please raise your hand. Our staff will come around with a handheld, and if you can identify yourself and also keep the question short.
My name is Horace Sheffield from Detroit. We have a clinic in my nonprofit, and we've done a lot of great work. Right now, the Senate Bill 279 in Michigan will allow family nurse or nurse practitioners to practice without having the supervision of a physician. There's only one primary care physician for 7,000 residents in this Detroit. Does your organization support such legislation?
The Obesity Medicine Association? Yes, we have several nurse practitioners. Actually, we have a large portion of our membership is nurse practitioners. We are not limited to physicians only. We have dietitians, psychologists, the whole multifactorial team of caregivers that are important to increase access to all types of treatment, including primary care, as well as obesity care, which would fit into primary care as well.
Kavita, as far as the trends, you talked about kids, and it's hard to change patterns, of course, when you're getting unhealthy foods. Where the obesity problem affects everybody, I believe it affects over 100 million people in this country, but looking at the data, is it more with low-income populations, rural, urban? Can you give us a feel of where the problem is the worst?
There's definitely disparities where there are higher burdens of obesity in deserts, food deserts, kind of deserts as the gentleman from Michigan was talking about, where you actually don't even have access to care, and then certainly kind of racial and ethnic lines. And we see it with gender as well. We see like higher rates in women in certain age. A lot of that, I think, Bob, is, again, going back to the way we have kind of medicalized everything. We won't do anything until someone's kind of in a catastrophic situation, and that ends up making all of these disparities much worse. And then on top of that, I think that we've seen something, I'll just kind of say, that has aligned with COVID that we've touched on today, is just the themes of, who's not getting care when they need to, as a result of kind of 3+ years of like change in access to care due to COVID. And it has been those exact same communities of color, more in many cases, more than not, women more so than men, and then in certain patterns, rural, but I see it in urban settings as well, where you don't have enough care providers, even in an incredibly dense urban setting like Washington, D.C. So I do think it's a combination of all of the above. I will say, there's one good thing that came out of COVID has been the telehealth access. Now,
Right.
Part of the problem has been literacy, though. So my entire population is almost exclusively Spanish speaking, and there are still very poor solutions for that virtual access for usually different languages. You would think that's easier with telephonic access. we have such a shortage of interpreters and providers who speak those languages. So we're also now making those same kind of racial, ethnic, language, education disparities way worse, even though we have this more ironically easy way to access care. So, the problems all stack up. So I'm hoping a lot of these bills and solutions put the literacy into that as part of it, because it has to be, or else you're just going to continue to solve the problem for a very select group.
But also regarding telehealth, which without doubt has exploded, but not everybody has high-speed access, internet access.
It's all of, it's and in fact, it's so funny you say that. So a lot of my patients, they get their access in their workplace because they can access public Wi-Fi. And it's been a godsend that we've been able to cover telehealth visits, because they are the people who are working at Giant on helping put your groceries into sacks, and they'll be able to call me to get a diabetes checkup in that 20-minute window, that they might be able to take a break and access the Wi-Fi through their employer.
Wow.
And so, and then I go to countries like Europe where it's ubiquitous and it's free, and I'm like, why can't we do this in the United States? But I ask that question a lot sometimes, Bob. So.
Well, yeah. Well, we could talk for another hour, but we are out of time. Please thank our two doctors for joining us.